I'm Saul Pressner, president of the ABD, and I practice biomimetic dentistry in New York City, as I said. And so it's now my deep pleasure to welcome Dr. Nejad. We're going to have a fun Q&A today's session. So thanks again, Matt, for joining us today.
Thanks for that amazing introduction, and I'm excited to be here on this beautiful morning.
Thank you. Thank you. So, Matt, to start out, what are your indications in your clinical practice for doing full coverage restorations?
Good question. So pretty much for me, and I think a lot of biomedic dentists, it comes down to replacing full coverage restorations. I don't really ever go to full coverage as my first choice unless I'm replacing. More or less, if I have sound intact walls or tooth structure, I do partial coverage varieties ranging from, inlays all the way up to like close to 3/4 or even 7/8 type ceramic restorations. But full coverage comes down to replacing. And then one more that comes up from time to time is in larger full mouth reconstructions. But again, there has to be damage that warrants it and some benefit, like repositioning the lingual cusp or something, like getting that extra contour can sometimes make a big difference on your occlusion design. So I find that coming up sometimes as well, but with a very non-retentive, minimal prep design approach for that.
I agree. I mean, we really try in my practice also to avoid full coverage, except in the cases you mentioned, replacing an old crown that's faulty with leaky margins, or in the other cases you mentioned. Yeah, I agree with you. What are some of your treatment criteria in recommending crown lengthening versus deep margin elevation procedures in some of your restorative work?
Oh yeah, great question. So I truthfully, we do crown lengthening only for aesthetic crown lengthening situations as part of a comprehensive treatment plan and trying to, address gingival discrepancy or even excessive gingival display. But in terms of like restorability, I would say I can't even think of one case where I've done to be able to restore it. And what I always end up doing in those scenarios is doing a deep margin elevation, explaining explain both procedures to the patient. I don't think you'll ever find a patient actually saying, no, I want to go with the surgical intervention approach. But I feel super good about doing it. And if there is a problem that warrants, crown lengthening, to do it after the fact, because there's nothing and absolutely nothing wrong with having like a restoration with a composite margin elevation in that cervical portion. It works great. There's even like finite element studies that show it's better to have something more flexible like composite in that region than to have a ceramic restoration go all the way down there. By the way, not to be confused with, I don't think there's a huge problem if you can get your ceramic restoration all the way down there. I do that all the time too, but it doesn't make me think that if they get a crown lengthening that I have to go back and replace it now because the margin elevation was unnecessary.
In your practice, how do you determine whether the treatment plan for direct versus indirect restoration?
It's hard to make a standardized set of criteria, in my opinion, and I find myself like finding scenarios that hold true most of the time, but not 100% of the time. So for me, I'll break down some scenarios. Okay, so like MO, DO, 3 surface, 1 proximal contact, always going to be a direct restoration. I will almost never go indirect on that. MOD, intracoronal restoration, I almost always prefer indirect. That's because for me to restore it well takes a significant amount of time. And I'm sure some people out there are faster than me, but I do pay very close attention to how much my patients are squirming and how they're getting uncomfortable. And when I'm doing that anatomy and doing a direct restoration and time starts getting into the 2+ hours, I start to see that patients are uncomfortable. That makes me uncomfortable. And I've just found that dividing it, giving them a break, doing either a same day indirect restoration or even just a separate, appointment is more comfortable for them. And I've also made it, and this is very, 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 very important in my opinion, I've made it where cost isn't a criteria for me. Like it doesn't, I don't profit more by doing something indirect. I've raised my direct fees to be proportional to the time I spend. And so when you factor it in, it's usually a little cheaper than an indirect because I usually overall spend a little less time. But when you factor in the lab work, lab bill, et cetera, my profitability is about the same on them. And I think that's important to not have incentives to try to like upsell something. So for me, MODs end up having the benefit of being a little more efficient on time overall, more comfortable for the patient. And then you get into the components of ideal minimizing polymerization stress, improving the physical properties, getting a stronger and stiffer final result. I think mechanically there's advantages to that. So MODs I tend to, but there's exceptions. I definitely do direct restoration.
Got it. Interesting. What is your protocol for immediate dent and sealing, and when do you feel it's indicated?
My views on immediate dent sealing. I think it's critical. It's like a must. There's really no doubt in my mind about that. There was a period when I first graduated where I didn't realize that it applied to all adhesive dentistry when dentin is involved. I looked at it more like for inlay and onlay, but when it was full coverage crown, I didn't need to go there. And that quickly changed when I saw the benefits. And so I use it all the time on every indirect restoration that has dentin involved. And it's my comfort zone. I don't feel comfortable to not do it. People always ask like, oh, if you have retention form and you're replacing a crown, is it really necessary? Well, it definitely improves the physical properties or the compressive strength and the fracture toughness of your final restoration.
In terms of indirect, what is your material of choice for indirect partial coverage restorations? And could you break down maybe several materials and scenarios in terms of which materials you'd prefer for certain scenarios, please?
Basically, lithium disilicate is my go-to for indirect. I have Emax and Lissy. Lissy's by GC. Lissy's what I use probably 95% of the time. I don't really make the decision to use Emax for any other reason except for I have some inventory of it. And if the shade is there, I'm very comfortable with the material. But I think Lissy is superior in many ways. I'm milling it, so I think it mills nicer. I think optically it's nicer. The crystal size is smaller crystals, less gray appearance. It mills super, super nice. And we were also pressing it for years before I was milling it. So GC Lissy has been my go-to for indirects, posterior specifically, some anterior. But on the anterior cosmetic cases, we still do feldspathic. We do feldspathic porcelain, fully hand layered, combining some digital technology, but we're not milling it. We're just, doing 3D models, and we can talk about that later. But feldspathic ceramic, a few different companies, GC being one of my favorite ones as well. But it has the highest aesthetics, I think. I've worked with amazing technicians, but I've just seen that at the end of the day, I can tell the difference. And so that's why we always come back to that.